Good evening, everyone, and welcome to this evening's webinar, courtesy of the Kenya Diabetes Study Group, KDSG. We're excited to have you guys join us once again. You may remember that this is the second part of our two-part series on diabetes in the geriatric population. We had the first part of this particular series done a few weeks back by Dr. Omari. Very exciting and insightful discussions that came out of that, not just limited to the special dynamics of the elderly, but also we looked at polypharmacy, issues to do with social and mental health in that particular age group when it comes to navigating diabetes and so on. So today evening, the second and final part of the series, we're excited to have our speaker, Dr. Rosslyn Ngugi, who currently serves as the president of KDSG and is also a consultant physician and endocrinologist, currently based at Kenyatta University Teaching, Research and Referral Hospital. So I'll just remind us all that for those of us with questions or comments, feel free to input that on the Q&A chat box, and we shall be taking those as soon as the slide presentation concludes. So welcome, Dr. Rosie.
Thank you, Oli, for that kind introduction. Can you see my slides?
Yes, we can.
Okay, perfect. I like the way you have said that this second and final part. I'm hoping by the end of this discussion, you'll want us to carry on because there are so many aspects with regards to management of several conditions in the elderly. But today we'll mainly be focusing on management of diabetes. And it was such a vast topic, so I apologize in advance if I'm going to go above time. But this is something that I'm very passionate about, and I'm even currently undergoing a course with an International Society of Gerontology and Geriatrics, just looking at key issues with regards to this special population. But today we'll focus on mainly management of diabetes, okay, in the elderly. Now, when we talk about the prevalence of diabetes in the elderly, what we found is the improvement of life expectancy in many countries, as well as lifestyle changes promoting obesity, have led to a global epidemic of diabetes in older adults. What we're looking at is globally about 19%, or an equivalent of 136 million people who are aged between 65 to 99 years of age are living with diabetes. And the projections made indicate that the number of people who are older than 65 years of age with diabetes will reach around 195 million by 2030 and 276 million by 2045. Why is this important? Because about half of the older adults tend to have prediabetes. And if you're diagnosed before the age of 65, what we found is you tend to find patients have a higher HbA1c. They're more likely to require or use insulin. And in this group, particularly, retinopathy is more common. And as we discuss management, you'll understand why it's important to understand this. And if you're diagnosed after the age of 65, you tend to have a lower A1C and you're less likely to use insulin because of the attendant risk of hypoglycemia. What is also known is older adults tend to have the highest rates of lower extremity amputation, myocardial infarction, visual impairment, end-stage renal disease. And patients with type 2 diabetes who are above 75 years of age tend to have double the rates of emergency department just because of hypoglycemia. So then what would be the rationale for ensuring that we provide high quality diabetes care for these elderly people? Why are they special? And that is because the highly prevalent nature of diabetes in aging population is characterized by key things. One, the complexity of its illness, and I'll explain the pathophysiology as we go along. The increased risk of medical comorbids, they may have hypertension, dyslipidemia, other things like arthritis, frequent falls, and then the early development of functional decline and the risk of frailty. And when these are coupled with common and widespread occurrence of delayed diagnosis, and frequent admission to hospital, and if you have clinical care systems like ours, which could be suboptimal, this makes elderly diabetes a special cohort. So how then would we go about it? So when you're thinking of diabetes in the elderly, it's very different from a type 1 young adult or a type 2 who's middle aged, because there are several things you need to think about. Number one, they have reduced physical activity because of the attendant, one, reduced metabolism and catabolic rate. At the same time, they have attendant arthritis. And then at that age, they'll probably tell you, why are you restricting my diet when I probably have 20 years to go? So how are you going to stop your grandmother or your elderly relative from eating what they want? They could have coexisting illnesses. And then they've probably had the diabetes for 20, 30 years. And then take into account genetics. It's very important to understand how diabetes played out in their parents to understand how it will be in this particular cohort. Then there's autoimmune phenomenon, which, as you know, as people age, you tend to have a larger percentage of autoimmune phenomenon. Like Dr. Maria talked about polypharmacy, and I feel like this should be a topic on its own, because one concept we are very afraid of is deprescribing, which is very key, particularly for our patients. And then the age-related changes in glucose metabolism, which we'll talk about. Now, all that coupled with the fact that in elderly patients, you have some degree of insulin resistance, which contributes to overall obesity and sarcopenia. The question is, how are you going to manage this patient? So key to all of this, when you look at all the guidelines, even the guidelines we released last year, we always talk about individualized care, whether you're a young patient or an elderly patient, but take into account an elderly patient who's either functionally dependent, which falls into category of frailty or dementia, or is at end of life care. How will you achieve this individualized care, taking into account the numerous drugs that the patient is on, recurrent hospitalization, whether it's because of frequent UTIs or URTIs, or the fact that they get electrolyte imbalances. And then there's also the therapy management, and you have to balance this vis-a-vis not getting hypoglycemia. And then this is a patient who, do they understand what it is that you're saying? Okay, can they see well? Can they hear you well? And then you'd have to think of what would be your treatment target. So when you think about all that, you'll have to figure out how to mesh everything together. So what are the key principles you need to understand when you're managing a patient with the diabetes in the elderly? One, you need a holistic, individualized care plan. And number two, it's also important to adopt a proactive risk and minimization approach. And you'll understand as I go along what it means when we say proactive is anticipate the risks as you go along, and then try and see where possible. Do you need to give a medication for everything that the patient presents with? And then now you focus on the patient's safety while avoiding hospital or emergency department admissions and institutionalization by recognizing early deterioration so that you can maintain quality of life. Then one key thing for most elderly patients we forget is what is most important. If you don't educate the families or the caregivers of these patients, this is where you end up getting complications. And at the end of the day, you cannot manage patients with diabetes, especially the elderly, if there's no interdisciplinary care pathway, okay? So what are the key things that will help you and guide your decisions? Number one, you want to stratify the risks that are common in older people, weigh the cost consideration and the cost benefit analysis. Remember, these are patients who are retired, no form of income. And one of the problems we have in this country is that, do we actually sit down and talk to people and prepare them for what retirement is going to entail? Because I get patients coming in and saying, you know, I was perfectly okay when I was working. When I retired, I developed diabetes or hypertension. Probably there all along, you just didn't do regular checks, yeah? Then look at the level of comorbid illness and of frailty, and then life expectancy to determine what level of care you want to institute. So if you want to do that, then it's very important you categorize these older people, because there's no shoe that fits all of them. So the first category is the functionally independent. Now, this category is characterized by people who are living independently. They have no important impairments of activities of daily living. And that means things like simple things like bathing, showering, feeding themselves, dressing themselves, going for walks, and also taking their medication. And they're receiving none or minimal caregiver support. That's the first category. Category 2 it represents individuals who, due to loss of function, and this increases the likelihood of requiring additional medical and social care. And these people are particularly important because they're at risk of admission in hospital. So it's further subcategorized into subcategory A, where it's the frail. And these are people who have a combination of fatigue, recent weight loss, severe restriction in their mobility and their strength. They have an increased propensity to falls and an increased risk of institutionalization. Those are the frailty that we talk about. But subcategory B is dementia. So they have a degree of cognitive impairment which has led to significant memory problems. And so you can imagine you tell them to take a certain medication, you've prescribed 10 pills to be taken twice a day, and half the time they're like, did I take this medication? Did I not? So things like that you need to think about. A degree of disorientation or a change in personality, and now are unable to self-care. Called illness or malignancy, and we anticipate a life expectancy that's reduced to less than 1 year. And so you have shift of goals depending on each of these categories. Now, once you have subcategorized them, the other thing you need to think about is what are these factors which could contribute to your medical or medicine-related adverse events? One, look at all the medication you're prescribed, and that's why we call it polypharmacy. Then there's inappropriate diarrhea, the GI dysfunction for the diabetes, another pill to overcome the side effect of the drugs that you've given. Then you give for hypertension, dyslipidemia. Then they also want to lose weight. They have the arthritis. By the time they're done, they're probably on 15 to 20 medications. Think of a presence of renal or liver disease. African culture has accorded is we take care of our own, the community feel. But what we've had now is a change where we're looking at community health promoters who also check on those who don't have any living children or never had any children or don't have that social support, because it's very important. I mean, would you prescribe someone like that having insulin and then they have dementia and they're living alone? Then you look at cognitive. When someone can barely see, how are you giving, how many actually take the time to actually see if your patient is understanding, and you ask them to repeat what it is that you have prescribed for them, and then also just basic self-management behaviors, and then take into account life expectancy. When you think about that, you're like, oh my God, how do you manage geriatrics? And that's why it gets interesting. So you have to think of the considerations when it comes to elderly. Then set your goals with the idea that you're not going to have hypoglycemia, but be cautious about which medication you're going to give. Now, you've noticed quite a number, and one of the questions I get asked by the medical officers is, why are there such a huge number of patients, the elderly, now presenting with diabetes? And it's because there's a concept called age-related glucose intolerance, whereby you have increased body fat and as a result also some peripheral insulin resistance on the background of a patient who has decreased beta cell function and overall insulin secretion. And even if you do produce some degree of insulin, there is a decreased number of insulin receptors, and there can be a defect in your post-receptor action. Insulin might up to 10% may end up actually developing diabetes because of the pathophysiology of aging. So if you have now the family history, that risk goes from 10 to 20% diabetes complications. And you don't actually think about it and say, could this be related to diabetes? The cognitive impairment, they were doing well, they could remember you, and you come back to visit your grandmother, and all of a sudden she can barely remember whether you got the medication, when she last saw you, things like depression. So they're managing depression, but they noted that she's developed lazy. Please assess these clients appropriately. Any form of disability, a patient comes and they say, oh, my grandmother fell. And they're like, what precipitated that? No, she's just old and clumsy. That's ageism, which we really need to stop. And then urine incontinence, which can be quite tricky because if you're an elderly gentleman, you probably have a benign prostatic hypertrophy. So how do you differentiate the two? Then you have physiological changes that are affecting medication in the elderly with diabetes, which I need you to think about. Because of slowed peristalsis, you have a longer exposure of the medications to the GI tract. So when you start thinking of the dose you'd prescribe, and you go without saying that you'd start at 500 milligrams, for some of the elderly, we actually start at 250 simply because of this. You have decreased hepatic metabolism and blood flow, so there's a slowed elimination of drugs, which are metabolized in the liver, which can predispose to hypoglycemia. Then you have as well decreased renal blood flow, and that is because of an increased duration of action and potential for toxicity. So you have to be careful about certain drugs, like your sulfonylureas, your insulins that you're using, and even your basic metformin, which people can stay on for over 50 years. And the clinician actually, there's clinical inertia, because you've said if it works, why change? But you're not looking at, every time I see a creatinine for a patient, I always ask, have you actually estimated the GFR? Don't look at just the numbers. Estimate the GFR. You'd be surprised how many patients we miss to have CKD. And when you think about it, there's also increased volume of distribution of your lipid-soluble drugs, thereby increasing your half-life of your drugs, right? And then now with the accumulation of the drug in circulation, you say the patient is unusually sensitive. Why are they getting hypos? And yet for other patients, they are not getting. It's simple, really. Just think of the liver and the renal function in these elderly patients. So a patient comes to you, and one of the things that is very key is your history and physical examination. Take the time there with their carer so you can get additional history. But if you are in category 1, where you're functionally independent, please talk to the patient directly. Let them feel included, okay? And even in category 2, those who are frail are still have good cognition. Please take the time to actually sit and talk to them. Then you'll do a physical examination, okay? And you have to be sure that you examine the patient fully, not just the system that they came with, because there are a lot of things that they will not tell you, but as you examine, then you go and you notice, okay, could the patient be having fecal impaction? Have they been feeling weak of late? And that's why your geriatric assessment is very important. Now, this, as I've come to learn, is actually quite important. And we will, I think it was actually touched a bit by Dr. Omari, where you look at various areas. Number one is your functional status. What is the general activities of daily living? Are they able to bath themselves? Can they dress themselves? Can they even prepare food and not only just feed themselves? What is their cognitive function? Do they understand? I usually start by introducing myself, and halfway through the session, I ask them, do you remember my name? And because you're one, establishing rapport, but trying to understand and see what their memory is like. Then their psychosocial status. If there's one group that you cannot ignore, is assess for their psychosocial support, because without that, you'll not be able to manage the patient. Then, of course, take into account their medical history and various comorbids, and then ask them for their basket of medicines that they've come with, okay? Then talk about their nutritional assessment, and that will be very key when they're seeing the dietitian. Some basic labs, if they're able to test themselves, it would be important because it guides you on management. Your fasting plasma glucose, your postprandial glucose, and your A1C, your lipid profile, kidney function tests, basic routine urinalysis, because you find a lot of them will not come presenting with symptoms of dysuria, but you'll end up finding an incidental urinary tract infection. The liver function test, ECG because of arrhythmias, and basic tests, just like your ophthalmologic exam like fundoscopy and your dietary assessment. Now, they don't typically present with your osmotic symptoms, your polyuria, polydipsia, because you have to think, if they're presenting with polyuria and it's a man, could it be because of also the attendant prostate enlargement in men? Yes, and most people will think it's that and leave it as that, never check for their diabetes. UTIs, recurrent UTIs in women, very common, but we never do just a basic random blood sugar. Polydipsia, any female who has had even 2 children or 1 child, as long as they carried the baby, it's important that you understand those who not have adopted, but they actually carried a pregnancy through. They may have issues with regards to urinary incontinence, very common with the female gender. So they'll always assume that is my norm. Please test to be sure. You give your patient with hypertension diuretics, you give them at night instead of during the day. Just think of how you're even affecting their sleep. And anyone with cardiovascular or neurological disorders, you can end up giving things like oxybutynin because of a neurogenic bladder when it's actually just diabetes. And then symptoms of polydipsia could be replaced by fatigue and cognitive defects. And then diabetes in itself can lead to a hypercoagulable state. So it increases the risk of stroke, acute coronary syndrome, or even intermittent claudication in the elderly. So think about that in the background of you've assessed the renal function, hepatic function. Is this patient at risk of hypoglycemia or neuroglycopenic symptoms? Look at all the drugs. Could there be drug-to-drug interactions, and are there any adverse reactions? It's very important that you understand that up to 30% of elderly patients tend to develop hypoglycemia, and this is related to their regime that they're using. And also the concept of decreased autonomic function, where you have reduced response and reduced counter-regulatory responses. Sometimes you ask yourself, how is this patient not realizing that they have a sugar of 3? There is no sweating, they're not irritable or angry or feeling that impending doom because of the fact that there's decreased autonomic function. Then you tell a patient, inject yourself before eating, and yet they've decided, I don't feel like eating. Not that they're unwell, they just don't feel like. So you really have to think about even your choice of medication. Then there's a concept of poor adherence to prescribed regimens. I have first-hand experience, I can tell you, since I take care of my elderly mother and grandmother. They can wake up today and say, I don't want to take medication. I know I need it, but I don't want to. So what do you do in such scenarios? So think of also things like social isolation. Do they have any form of cognitive impairment? Can they afford the regimen that you're giving? Remember, these are people who are reliant on their families or, well, social health insurance to support them. Could they have psychiatric problems like depression and anxiety? Do they have access to this medical care? They have decreased physical activity. And then you tell them, make sure that they prepare in every meal vegetables. Who's going to grow those vegetables? Who's going to go to the farm and then try and get those vegetables? Clean the vegetables, prepare. Have you thought about that in someone who has arthritis or has tremors? Alteration in their senses like vision, taste, and smell. They have difficulty even consuming. You prepare your food, but then they have difficulty even digesting, and any coexisting diseases. So your treatment approach would be then, one, I want to prevent hypoglycemia, but what are my targets at the end of the day? And it's very important. This is one cohort where you have to do monitoring of your blood glucose levels because they may have some autonomic dysregulation, so they're not able to tell you the symptoms of hypo or hyper. And then, of course, annual assessment of your diabetes complications and any geriatric comorbids. So one, it should be individualized. Two, the risk of polypharmacy. So there's a concept of de-prescribing. Ensure that it's safe for the patient and the treatment has to be practical, such that you look at the functional limitations and say, is this going to be useful for my patient or not? So these are drugs that you're very familiar with. So let's talk about them in the concept of the elderly. So guiding principles are one, and I keep stressing this. Choose medications with low risk of hypoglycemia. De-intensify, de-prescribe, or simplify these complex regimens to reduce the risk of hypoglycemia. Then think about your cost and insurance coverage because of non-adherence. So when you're looking at drug classes, you look at the classes with no or low risk of hypos, your DPP-4s, your GLP-1s, metformin, SGLT2 or TZDs. But those with a moderate risk are your insulin secretagogues and your basal insulin, which we'll go and discuss. So the 3 steps are, one, identify the best treatment, select these medicines cleverly, and then, of course, it's evidence-based. So let's start with metformin. It has good advantages. It's weight neutral, doesn't have a tendency of causing weight loss, and relatively inexpensive. So you would give that to an obese diabetic patient with your focus being your A1C reduction, and it's been shown to reduce all-cause mortality. But who wouldn't you give it to? If your patient is already frail, we've actually seen it can cause further weight loss. And if your patient is anorexic or underweight, perhaps it's not the ideal drug to give, especially if they have compromised renal or hepatic function. But what we do is we'd even tell you start at a lower dose. Even 250 is adequate. And then you carefully up titrate, ensuring you're avoiding GI intolerance. So the first option would be a controlled release formulation rather than the regular one to avoid the GI intolerance. But they say you have to be extremely careful for the elderly patients who are frail or above 80. There's a risk of lactic acidosis is very real in them and the GI intolerance. And of course, any of your patients who are on metformin, check their B12 status. Remember, these are patients not feeding well. So the likelihood of them getting paresthesias because of B12 deficiency is very high. And where necessary, ensure that you supplement it. What about your thiazolidinediones? Not commonly used, but still in use, of course, in both public and private hospitals. The issue we have in elderly subjects is the fluid retention and the propensity to develop or worsen heart failure because of this fluid retention and hepatic toxicity. Now, in this cohort of patients, particularly who are predisposed to osteoporosis and also cancers, you really have to be careful about wanting to choose TZDs. So it would not be the drug recommended over metformin, we'd still stick to metformin as first line. Then we come to the one that is a bone of contention, your sulfonylureas. Amazing when it comes to managing hyperglycemia, right? Insulin secretagogues. And you find up to 70% of the prescriptions are given to patients over 60 years of age because it's very well tolerated. But what is the problem? Hypoglycemia. And there's nothing we fear more than hypoglycemia, especially in the elderly. So one of the things you'll see, even we managed to remove from the essentials medical list was the drug glibenclamide because it has a half-life of up to 72 hours. So you have a patient with a hypo, you'll have to keep them in because they can go back into hypoglycemia. So the drugs that are advocated are your gliclazide and glipizide. So generally, please, my plea to you all, if there's one take-home message, please avoid glibenclamide in your elderly diabetic subjects. And then preferably use one that requires just a single daily dosing schedule. Start low, then go on up titrating. But of course, it's not the drug of choice when it comes to hypos or patients with irregular meal patterns. Patients, especially from category 2 and 3, the irregularly eating habits, they skip meals, and then yet they've taken the medication in the morning. For sure, they will get a hypo. Then you have meglitinides. It used to be a very common drug. I remember almost 15 years ago, it would still be used. And the beauty about these drugs was you could allow the patient to eat. And I remember then it used to be repaglinide. Then you give them just 1 milligram and used to be quite efficient, even if you had moderate renal impairment and normal hepatic function. But it was found to also cause hypoglycemia. And it's also not able to handle the fasting sugars. So you really, really have to be careful about prescribing this. We don't advocate for it actually in the guidelines. Then the drug that everyone is talking about, would you use it in the elderly? So if you have an overweight or obese patient who's got osteoarthritis, severe osteoporosis, can barely move, you want them to move, and your A1Cs are not quite to target, I mean, you'd be like, this is a good drug. It's once a week, right? And this is a patient, supposing they're category 2, and they've developed dementia, and or it's just early dementia, are they likely to remember that once a week injection? You know, it's easy to remember that daily pill, but once a week, the beauty about it is there's very minimal or hardly any risk of hypoglycemia. So of course, it's quite ideal. The problem is the GI disturbance. Remember that we've already said that there's reduced blood flow and there's reduced motility. Then when you already give another drug which slows down motility and a patient already gets fecal impaction, you really need to think twice about their use. So you'd use it in a young elderly patient, 65 to 75, then that's really good. But above 75, perhaps think twice. Now, the drug we all love is this, DPP-4s. I think for me, this was the game changer when it was first introduced, because we thought this is the drug we need to give our elderly patients. You can give it to them with those with normal to moderate renal impairment. You can renal dose them or use the renal friendly ones. In one of the studies, actually, the verified trial is the only one where they looked at patients, a subgroup, who are above the age of 75 years of age. And they said you could actually safely do it, use these drugs because it was not causing hypoglycemia. And the beauty about this is they're weight neutral. So regardless of whether you're frail, that's subcategory A in regards to category 2, or whether you're robust and you're category 1, you're functionally independent, even the ones who are in category 3 who are at end of life, you can still use these amazing drugs. Yes, but now comes this SGLT2. Now the problem is in this age group, you probably have attendant hypertension, heart failure, chronic kidney disease. So because of the multiple pleiotropic effects, you're thinking, this is a fantastic drug to give. However, these are the patients who, because of the constant urine incontinence, I don't know if your grandmother will tell you, I probably peed my pants. So you keep giving them the diapers to use, if not the pads, but they're not changing as frequently. So the risks of urinary and genital infection are quite high. And because of the fact that it causes quite a bit of osmotic diuresis, there could be a falsely elevated increased hematocrit. And in some cases, they've also noted it can cause hyperparathyroidism. So that's about the orals. So let's go to the elephant in the room, insulin. We all know older patients have a higher probability of needing insulin. They have a higher risk of cardiovascular events, especially if your postprandial glucose is not managed. So the thing you need to think about before you give insulin, and I want you to pause and think about this. Is this patient physically and cognitively capable of administering the dose by themselves? Can they monitor their blood glucose? And are they able to recognize and treat their hypoglycemia? If yes, then give, right? And you keep reassessing frequently. However, if a patient has reduced adherence to insulin injection, like they inject and then they're like, I have a patient who we told them inject basal bolus. They said they were focused. And so we said inject at 6 a.m., at 1 p.m., and 6 p.m. the boluses, and at 10 p.m. you do your basal insulin. But the patient would inject at 6 a.m. and eat at 9 a.m. Okay? And then because they've eaten late, their breakfast, then they'd have lunchtime at around 3 p.m. So no relation between the insulin and the meals. And that's when you realize you need to understand and educate them about hypoglycemia. So who would you give the insulin to? If your A1C is more than 9.5% in a drug-naive patient the first time because of glucotoxicity, or you're on maximum of 3 oral antidiabetics, A1C is still not controlled, then start thinking, could we add like a basal insulin? And then, of course, it's a no-brainer if you come in complications like your HHS, your DKA, acute MI, you're treated in a critical care setting, awaiting surgery. The only way you can manage while in the hospital is if you actually use insulin rather than your oral antidiabetic agents. But just remember, and again, I think my slides, there's hypoglycemia everywhere. For this group of patients, hypoglycemia, are they able to recognize and treat? Or sometimes they even forget to report it because of their cognitive dysfunction. Do you overtreat because of fear of hypoglycemia? Sometimes do you think, I'm feeling a bit weak, I don't think I ate very well, so let me skip the insulin, and the patient is a type 1? And the problem is that you don't have too many trials with regards to geriatric patients and insulin therapy. So what have the experts then come up with? That patients with type 1 diabetes should not have their insulin stopped. Rather, you reduce their insulin to the required amount or change your insulin where appropriate. Now, the other one that could be a contention is avoid human insulins and rather use insulin analogs. And that is because of the delayed peak, and then you're not too sure about their pharmacokinetics. Yes? What we advocate for is you prefer the long-acting insulins, and that is because of lack of the peak levels. They maintain just a general trough, so you're not likely to get hypoglycemia. So if you're going to use insulin, please use a long-acting insulin rather than your short-acting or your rapid-acting insulins. And one of the things that we always say, and you've always been told, is when we first started off with, say, inject, then eat 15 minutes later. Now, if you're not too sure about your elderly patient with dementia, whether they're going to eat or not, I tell them that why don't we, one, use an insulin which is flexible, that if you eat now, and you're sure that the patient has fed well, then you can inject after. And we'd always say, especially for your elderly patients, please consider injecting insulin after the meal rather than before. But for patients who are in category 3, the last days of life, and they have type 2 diabetes, please stop insulin. And we allow for levels of between 6 to 15 millimoles per liter of glucose when you're managing end-of-life care. But the general thing is look at what the day has been like. If they refuse to have repeated monitoring, this is where technology comes in, and you'd even think of using a CGM so that the patient doesn't complain of the constant pricking, and then of course support and empowerment of the individual. So that's medication. Why we've talked briefly about lifestyle is because that's a whole other topic. But one of the things a nutritionist will tell you is optimize your nutritional intake and your protein intake so as to reduce your risk of frailty and sarcopenia. When you're talking about exercise, and we'll talk a little bit about it in the next slide, is what exercises would you rather aerobic activity or weight bearing? Surprisingly, because of the risk of frailty and sarcopenia, we actually advocate for, and we start saying any lady who's even going into menopause should be doing resistance training just to be able to build up your muscle. And then, of course, those who are overweight or obese, you try and get exercises that are safe. So when you're thinking about a diet, we're looking at total calories, and its distribution should be almost standard based on the dietary therapy. But one of the things you need to think about is it accurate for this patient, appropriate, readily available? Is it acceptable to the patient, and does it sound attractive enough to them? And you think it's something that you can be able to achieve and afford And then is it something that is palatable to them? Because no matter how much you prescribe, if they're not willing to take it, then that diet plan remains as just that, a plan. Okay? When you're looking at exercise, the whole idea is you're focusing on improving your glucose tolerance, improving your oxygen consumption, increasing your muscle strength, because you want these patients to try and move. Just basic walking makes a very big difference. And it also helps with the other comorbids like decreasing your blood pressure and improving your lipid profile. The only thing though is you have to be careful about how you prescribe exercise because of the risk of sudden cardiac death, hypoglycemia, and the foot and joint injuries. So you see why you need to have first a detailed medical evaluation before you prescribe exercise, because exercise should be a prescription. So when you look at some of the challenges, you have to be careful that your diet plans don't lead to unnecessary weight loss, and an exercise program which is tailored to the patient. Are you category 1, 2, or 3? If you're category 1, then it's more of keeping fit and exercising. But if you're category 2 and 3, then you want to try and maintain gait balance and functional capacity. Another thing is, one of the other challenges is you first assess their clinical and functional status, then work out what is your goal, what's the quality of life that this patient needs. And one of the things we're missing a lot of prediabetes, particularly in the elderly, so that by the time they're presenting, they're needing insulin. So the onus is on us. Every time you find a geriatric patient, please do a random blood sugar. And we have treatment goals based on stage 1, which we call healthy, but it's essentially category 1, functionally dependent, A1C of between 7 to 7.5. If you are in category 2, where you have multiple comorbids and more than 2 impairments of activities of daily living, 8%. End of life, please don't look at the A1C. The whole idea here is avoid hypoglycemia. So a sugar of between 6 to 15 is permissible. So we'll tell you how to focus on these treatment goals and whether to prescribe or deprescribe. And then overuse. And I believe this is a very big problem. Half the time when my elderly patients come to me, I end up deprescribing and they get very anxious. But I tell them, you know, some of this medication you don't need. And there's actually evidence to show. There's a trial that was conducted in 2016, which showed that up to 44% of the patients above the age of 65 had an A1C less than 7%. And for what? And yet when they looked at a sub-cohort, up to 27% already had cardiovascular risk factors like your ischemic heart disease and congestive heart failure. So our over-treatment is actually making these patients worse. And that's why they came up with that concept of the age-neutral historic target of less than 7% is fallacious and based on results of studies which didn't allow for enrollment of patients age 65 years or older. So this glycemic control goals should not translate to older patients. And that's why we come up with different targets. So this is what you do. You have a fit older adult with diabetes. Your target is 7.5. Your intervention would be that you avoid initiating new agents which can cause hypoglycemia or exaggerated weight loss. If there's a degree of moderate to severe frailty, you want to target an A1C of 8%. And this is where you can do your DPP-4s and your longer acting insulins. Assess them. If they're at risk of heart failure, avoid TZDs. If you already have issues of recurrent infections and they're already having issues with balance and frequent falls, perhaps SGLT2s may not be your best option. But if it's someone who can be able to understand, then you can give it. For very severe frailty, 8.5%, the drug we will give is DPP-4s. If they need insulin, the long-acting insulin. But the most important here, educate their caregivers, especially with regards to hypoglycemia. One of the things I always say is the minute your elderly patient changes their behavior, check the sugars. That is likely a hypoglycemic episode. What about deprescribing? You've already gotten to an A1C of 7%. Look at the long-acting sulfonylurea. Stop it. You don't really need it, do you? And then consider appropriate dosage in the setting of renal function. If you have moderate to severe frailty, at 7.5%, no business giving sulfonylurea or TZDs. The things you have to think about is, can we use metformin or your DPP-4s? Very severe, please stop your insulin, your short-acting insulins, and your sulfonylureas, most important. And any therapy that promotes weight loss will actually worsen your sarcopenia. Your patient won't even be able to get out of bed. What about end-of-life care? People don't want to talk about this, but it's very important. So you want to tailor your diabetes therapy and minimize your side effects. The whole idea is avoid hypoglycemia and treat symptomatic hyperglycemia where necessary, okay? But otherwise, don't go above and beyond to be very strict that you're focusing on an A1C or that the sugar has to be below 10. If they're comfortable and not symptomatic, please ensure that you maintain the respect and dignity of that patient and they're comfortable, because at the end of the day, what is most important is they're painless and symptom-free. I cannot end this session without talking about mental disorders, frequently missed, especially in this group. And we found mental disorders are contributing to, one, the development and poor outcomes with regards to the diabetes. So if you actually treat, it makes such a big difference with regards to, one, adherence and them understanding. And please involve them in the management. You know, we always talk to their caregivers, their children, but their people, especially if they're functionally and their cognitive capacity is good. Why do you talk to the children or their caregivers? Talk to the patient first, then translate this information to the caregiver, and you will find they have better outcomes, okay? And I leave you with this. You cannot manage diabetes if you don't have an interdisciplinary team. You need a geriatrician, like some of us budding ones, at least a community health provider, an occupational therapist, physical therapist, an endocrinologist, a nutritionist or dietitian, at the end of the day, taking care of this patient. But unique considerations you need to think about is, can they afford? Are the services accessible? Basic things. I want you to think basic. Where will they get their food from? Can they cook? What is it that you're prescribing? When you start prescribing broccoli to an 85-year-old and she's never tasted that, yet you're telling them to eat greens, can you be at least a bit more realistic when it comes to them? And then when you're taking time to assess a patient, some basic things, can they see? Can they hear you? Do they understand? What is their mobility and dexterity makes a very big difference. And so that's where patient education is very key. So where possible, use visual aids. And these are the key things you always have to assess. Their foot health, are they getting their vaccines? Can they hear? Do they need hearing aids? Are they seeing well? Dental, some basic things. A lady was prescribed food and then she opened her mouth and she had like 3 teeth. And she's told, I'm told to take meat. And she's like, how am I supposed to do that? You know? And then, of course, no smoking and taking medication where necessary. And then technology. How many of you take care of geriatric patients and then you tell them, come and see me every 2 weeks? How practical is it? And so one of the things we want to do is embrace technology. One, when it comes to monitoring, if they can afford, why not use the technology? If you can be able to educate the caregivers, then you can do remote monitoring and communication. Now we have the younger doctors willing to go and do home-based care. Try and avoid having your elderly patient because it's very disruptive. And every time you change, you know, they are creatures of habit. So if you know you wake up at 6 o'clock, you have your cup of tea, then you'll go and shower. But that day is disrupted because of the hospital visit. It disrupts their whole routine, which can be very frustrating. So some of the things you need to think about is embracing technology, because the pharmacy can send reminders. You're due to pick your drugs. If they're not complete, why aren't they complete? You understand? Embrace technology by having these telehealth appointments, yes? And then through that, you can have your social support groups and then remote monitoring with your diabetes care team. So I leave you with this. For adequate care of the elderly patient with diabetes, there is need for interdisciplinary management, which requires a coordinated team effort to address the unique challenges faced by this population. And by embracing collaboration, you improve your patient outcomes and quality of life for the elderly individuals living with diabetes. And engaging in the elderly, themselves in their care through education and support is very vital to achieving successful management of their condition. Otherwise, you'll be faced with patients like this who think diabetes is affecting her eyesight, so she has trouble seeing the consequences of her poor food choices. And with that, I am done. Thank you very much for your attention. Back to you, Olive. I hope I didn't
Thank
go over.
you.
Yeah. Okay.
No, not at all. Thank you so much, Dr. Rosslyn, for that excellent presentation. I think you anticipated most of the questions because as you were talking, most of what had been put in the chat box, you did manage to answer. So thank you very much once again for sharing your expertise with the audience this evening. So in the next few minutes, I'll just read out a few questions, some which I've lumped together. So that you can be able to answer those. So maybe just if you could comment on the aspect regarding the relationship between depression and diabetes in the geriatric population. Is there a locally validated tool that you can recommend for routine screening? Dr. Rosie?
I realized I was talking without, while I was muted, yes. So there's a geriatric depression scale that is available, and it only takes about 6 minutes to assess, but it's almost similar to the PHQ-9. And based on that, you can be able to use that and then assess for it, because for these patients who have been determined to have depression, we actually find, one, they don't handle the diagnosis of diabetes well because they think it's just one more comorbidity on top of the other problems they're experiencing. Number two, they're less likely to be adherent to the medication. And we find actually when you come to outcomes, they're the ones who are more likely to get complications than compared to those counterparts who are not having depression. So yes, the geriatric depression scale is there.
Great, excellent. Thank you so much for that. There's another question by an anonymous attendee, and the gist of it basically is a case scenario that they're presenting around an elderly woman of age around 65 who's on insulin and not controlled on maximum doses of oral hypoglycemic agents, but is only on the insulin for 2 weeks in total for any particular month due to financial constraints. What can be done to help her in the long term?
So two things. Number one, it probably means that she's probably had diabetes for quite some time if she's on maximum doses of the oglars, and she's also using insulin. So these are the things that we are looking at. The cost vis-a-vis what's the current A1C, what is the capability of this patient, and how much have we educated. The fact that she's 65 means she's young in terms of when we're looking at elderly diabetics. But when you look at the cost of multiple oglars vis-a-vis insulin, insulin is much cheaper. So you give them two options. Number one is that we can remove all the oral hypoglycemic agents and just give her insulin, because the issue is cost implications. So if you want to ensure that the patient, you want to overall reduce the microvascular complications, the only drug that has been found to be useful, that has anti-inflammatory, glucose lowering, antithrombotic, is insulin. So one option is just tell her, what if I remove all these oral hypoglycemics? Because the cost is probably, say, 8 to 10,000, probably even more if it's an original. And your insulin is about 1,500 per month. If I removed the orals and I just gave you insulin, would you be compliant? If she starts giving excuses, then you know that there's also an issue of dietary, because there's so many other things you have to think about. The fact that she keeps coming always as a sense of urgency. When it is 25, she's probably developed the osmotic symptoms, and that's why she's worried. She doesn't want to be admitted. That also means she's got attention-seeking tendencies. So you also have to address the mental state and see why she's coming only when the sugars are poorly controlled, yet she knows that when it goes above that, the likelihood of admission is very high. So there are various things that you have to think about. And then sometimes I find these patients on insulin are so afraid of hypoglycemia. One of the things we'll tell them is, if we cut out the orals, then you can be able to monitor, and you also then use your insulin, then you'll be in a better place. Yes.
Great. I hope that's answered. The other question on the chat box is regarding the relationship between CKD in diabetes amongst the HIV population. Is there increased risk, and which oral glucose lowering agents would you recommend in the HIV population?
So I'm assuming you're talking about the elderly diabetic patient with HIV and diabetes. So one of the key things, remember that you are not allowed to use metformin if your eGFR is less than 30 mLs per minute and your risk of then lactic acidosis and toxicity is increased. Like I've told you, now we prefer the DPP4 agents because one, they're weight neutral, because one of the things you worry about is also sarcopenia with regards to your HIV patients. Then number two, it's because of that weight neutral, you're not likely to lose weight, you're not likely to get hypoglycemia. And for those with CKD, there you can either renal dose your DPP4s, whether it's sitagliptin or vildagliptin. And if you're using drugs like your linagliptin or teneligliptin, then there's no need of renal dosing, and it would still be the preferred choice. However, in the event that they have developed CKD, you would still consider using the SGLT2 inhibitor if you think you can be able to prevent further progression and the patient is able to maintain one good hygiene, able to maintain hydration well, but well within what is advocated for. Because one of the things is by the time you're in stage 4 or 5, we have to be careful about the amount of fluids that we allow our patient.
Great. Okay. Thank you for that. I think we have 2 minutes left, and I'll try and go through one or two more questions. So there's a question I think that most of us encounter in routine care regarding the choice of natural treatment vis-a-vis the conventional therapy, as you've discussed. Have you had such scenarios, especially with the geriatric population, who always feel like there may be another way of reversing their diabetes? And are you familiar with any what would otherwise be called in our setting herbal treatment that would work? Or in terms of advice, how would you navigate that scenario?
I was expecting that because that is the number one group. They tell them, I am pretty sure there's herbal remedies. I've managed to stay 60 or 70 years without diabetes, and that is probably because of diet. So you'll probably hear of things like the use of berberine. In fact, one of my patients came the other day with literature on the use of berberine as a natural remedy. But you see, the concept is if you understand diabetes, the problem we are having with the elderly is the degree of insulin resistance in this particular group of patients. So if you can be able to work on the diet, exercise is one that we cannot be able to be very aggressive with. In the younger elderly, because there's the young elderly, that is 65 to 75, then there's a concept of adding exercise plus the diet where we focus on mainly low carb diets. But I usually would advocate for telling them we try with the metformin, and then once we've able to achieve an A1C of 7%, we can actually stop and see. My problem is the level of insulin resistance. So these patients come back barely a year, and now they've noted the sugars continue to rise. So I would not advocate for herbal medication for one simple reason: polypharmacy. The patient doesn't come just with diabetes. So they're on medication for hypertension, for dyslipidemia, for arthritis, possible Addison's, urine incontinence or retention. They are on medication for constipation. Then they are on ginkgo biloba for memory. Then they are on medication that they're given also for memory, that we give our cerebroproteins. And on top of that, you're giving them multivitamins. And you've seen the fish oils, I don't know, B complex. I had one patient who was taking 10 different multivitamins in the hope of trying to reverse the diabetes, but we are not very successful with that. So unless you sit down and work out a plan with the nutritionist, I don't advocate for herbal. What I advocate for is diet. Don't be so quick to start a patient on medication, especially the elderly. They will not take it unless they've come in an acute emergency. But unless they buy into the idea that this is important and they understand the implications of not taking the medication, I can tell you for a fact, they will just keep throwing the medication. So key is education, education, education. Yeah.
Thank you so much, Rosie. I think that's very clear. To close our Q&A session, maybe just some comments on sleep disturbance. That's a very common presentation we find amongst the elderly, and sleep disorders in the full spectrum. So in terms of navigating it, considering the pill burden issue, polypharmacy, psychosocial issues that may be contributing, as well as neurocognitive disorders. How best would the practitioners navigate sleep disturbance in the context of DM in the elderly?
That's like a whole topic when we are in my curriculum for geriatrics. That's like a whole sleep disorders alone, because it's not only diabetes. Like you've said, if you're talking about a diabetes patient, just look at one, there's obviously alteration in your sleep pattern as you grow older. Okay, then number two is the medication that we are prescribing. You're prescribing diuretics for the patients with hypertension, and you don't tell them to take it during the day, they take it at night. Then there are patients who, because of their natural habit, they will wake up. So if you try and knock off their sleep, you find that there is now increased bedwetting. So as a result, you end up giving them drugs to prevent the incontinence. So they end up getting urine retention. So we try for more natural, like avoid. A lot of my patients now are getting tech savvy. So like I have a patient who is always on, surprisingly, Facebook, just checking what is latest, what is in the updates currently. And so we say, we avoid television or any type of social media for 2 hours before bed. We try and focus on reading the Bible, not even the newspaper, because it can get them very agitated. If they can get any soothing music or gospel music for those who are religiously inclined, then those are the kind that we would advocate for rather than giving the medication. If you're really pushed to the corner, that's when you try and use your melatonin, but you'll find very few people respond to that. So what I usually tell them is, if your sleep disappears, say for 2 hours, wake up, read your Bible, say your prayers, but don't fight it. And then when the sleep does come in the middle of the day, so one of the things we notice is they nap a lot during the day. So we tell them in the morning, you'll wake up, have your breakfast, do your activities. Afternoon, when you're feeling sleepy, that's when you go and take your walk. And try as much as possible to push it till 6 o'clock, have your early dinner, then you can sleep at 8 p.m. In the event that you wake up at 2 a.m., that's all right. You can sit and read. And when you go back to bed at 4 a.m., it keeps you going until 8 a.m. So we try and avoid the daytime naps as much as possible, because the elderly, you almost end up reverting to like how it was when you were a child. And so if you have a good afternoon nap that disrupts your evening pattern. But generally, please try and avoid, of course, your benzodiazepines because it affects your cognitive function and your neurocognitive functionality. So they end up being drowsy and they can get frequent falls as a result. But it's a very complex. There are a lot of factors you have to take into account. But this particular cohort of patients are very interesting. They're like a puzzle which you have to try and ensure you piece the pieces correctly so that you avoid letting go of others as you try and manage the rest.
Very well, very well. Thank you so much for those insights, Dr. Rosie. It's good to note that your geriatric patients are on Facebook. Please ask them to follow KDSG so that they can get the correct health messaging and they can always shoot their questions directly to the experts. So I think that brings us to the close of the webinar. Thank you so much. I think the take-home message is very clear. Individualize your treatment and have a holistic approach as far as how to manage the elderly. Not all glucose-lowering agents are the same, so know what is right for your elderly patient, know when to titrate, know when to come off some of those agents. Dr. Rosie, you couldn't have done a better job. We are very, very grateful for your time and sacrifice to be able to take us through this particular second part of the geriatric series. And we look forward to having you back again. As you've said, a lot of other topics that we need to delve a bit deeper into, like the last one that you've discussed on sleep disorders. So we'll definitely be inviting you back to be able to share some of those. Maybe just a parting shot as we come to a close. Take home message from you kindly.
Thank you, Olive. And I am glad I changed your mind when you said second and final. You realize how important it's a very neglected special population, the elderly. And let's be honest, we are all aging, and at some point you'd want this kind of care. But some of the things I think we need to do is start collecting data on our geriatrics with regards to management, whether they have hypertension or any other comorbids, because this is how we lobby for policy change. You need your insurance even more in this special type of population because that's when your needs are more. And yet that is a time when you can barely get any insurance cover. So every time you've got a patient in front of you, that's a human being. Yes, it takes time to be able to assess them. But one of the things I really find is if at the very first instance, what your elderly patient undergoes a full geriatric assessment, it actually changes their pathway to having a good quality of life. So if you could spend an extra 10 minutes just taking your time to do an adequate geriatric assessment. Then number 2, consult where necessary. Number 3, we've talked about polypharmacy. Please consider deprescribing. Some of the medication we're giving is not urgent, not important, and try and reduce the pill burden. And I'm encouraging those who are interested in geriatrics to reach out because hopefully in the near future we'll be able to have a geriatric association. But others, thank you very much for, I must say, you're head of education in KDSG, and I can see the difference it's making because we are having more webinars where people are interested in what it is, the special populations and the different aspects, because no shoe fits one foot. So we are encouraging the members, if there are any topics that you'd like to discuss, every Tuesday or every alternate Tuesday, we are available. The technical experts are available, and we are more than happy to host these webinars without requiring a sponsor. All we need is just interest. And for those of you who are interested, please reach out, join KDSG. There are exciting things going on as we grow as a society. Otherwise, thank you very much for having stayed till the end on the topic of management of diabetes in geriatrics. Have a good night.
Thank you all. That's it from us. Remember, the KDSG annual conference is coming up in May. Look out for that on our socials. We shall be sharing out more information as the days draw near. Thank you all and have a lovely, lovely evening.
Thank you. 7th to 10th of May, you don't want to miss the annual conference. And also there's an obesity conference coming up. Good night, all.
Thank you so much. Good night.